Welcome to the On the Pen, the Weekly Dose podcast, your one-stop shop for obesity medicine news with your host, man on the pen, Dave Knapp. Welcome to On the Pen, the Weekly Dose podcast for this Tuesday, May 13th, 2025. I'm your host, Dave Knapp, man on the Manjaro. That's why I'm here. You are on the pen. Wegovy, Saxenda, Victoza, Trulicity, Manjaro, Zepbound, Compound. This pen right here. That's what we talk about here every week as we continue to build the first patient-centric obesity medicine news platform. Thank you for being along here at On the Pen each and every week. Hey, if you're just joining us, jump down and give that podcast a 5-star rating and review as we march towards our goal to top 10 by 40. That's right. Within 3 weeks from now, I will be 40 years old. June 7th, I turned 40 years old. Pretty monumental birthday. It feels big, but it will feel even greater if we can reach the top 10 in podcasts that week, by that week, and the top 10 on Substack. Of course, we've already hit the top 10 on Substack in the trending list. We'd like to hit that on the bestsellers as well. If you want to help us out, we're building the first patient-centric news media platform over at onthepen.substack.com. You can sign up there for free. Please go do that right now today. Help us reach our goal of a top 10 by 40. You can sign up for free there, or if you want to be part of building something special, and we'll have some amazing announcements in the coming weeks here about things that we're doing to build out, but you can do that. You can be a part of that, get in on the ground floor at onthepen.substack.com, become a paid member as well. So thank you for helping us to reach that goal of top 10 by 40. But we've got a huge news week this week. Of course, we covered yesterday the press briefing at the White House as President Trump signed a massive executive order that could have sweeping implications about accessibility, not only to GLP-1 medications, but medications as well. The idea of spreading the cost of these drugs around the world to other developed countries, rather than the American people always footing the bill for not only the innovation, but the profitability of these pharmaceutical companies. I happen to really think that this could be a major game changer. So we're going to get into the nitty gritty on that a little bit today, because we covered it as it dropped yesterday. We covered it a little bit as we joined live and listened in, but we definitely got the meat on the bones from the actual executive order, and we're going to go over that today. And then, one topic leads into another as we weave together this tapestry of news and really, when you zoom out, this tapestry is just a story of accessibility, right? Because all the innovation in the world, retatrutide, mazdutide, maritide, survodutide, vikingtide, all the utides out there mean absolutely nothing if people cannot access them. And that seems to be what every story weaves into. So we're going to weave the story together, because you heard last week, CVS Caremark made this huge announcement about the switching of all of their obesity medications over from Zepbound to Wegovy in a partnership with Novo Nordisk. We're going to cover what the implications are, but we're going to give you some actionable items. We're going to give you what you can do now to fight against it. And we've got a great interview with a gentleman, he's a physician's assistant, Joe Zucchi, who started a massive change.org petition. We're going to have an interview with him a little bit later on, and we're going to get into the things that you can do right now. But if this thing happens to go through on July 1st, we're going to give you the rundown, and this will all be available for you over at substack.com on our Substack. We're going to give you what you need to do once July 1st comes, and how you can position yourself best to stay on Zepbound if that is the decision that you and your medical provider take. So let's jump into the news without further ado. But before we do, I want to thank our sponsor, Ro, who helps us here at On the Pen bring this to you each and every week. Give them some love. The Ro Body Program patients lose 15 to 20% in their body 15 to 20% of their body weight in a year when coupling these medications with lifestyle modifications. The Ro platform is amazing. Of course, you can get the single dose Zepbound vials now directly through their platform. You'll be able to get the cash pay Wegovy there as well. But why would you if you can get the Zepbound vials, right? But you can get the Zepbound vials 2.5 milligrams all the way to 10 through the Ro platform. Never have to leave it. You just order it as it's prescribed through the Ro app, and you'll get it right to your doorstep. It's an amazing, seamless process through Ro. So thank you, Ro, for sponsoring what we do here. But let's get into this week's news. So President Donald J. Trump, as we talked about, signed one of the most aggressive moves that we've seen in modern history to attempt to bring down the prices of prescription drugs in America. We talked about a lot on this stream that we had yesterday. Listen, every administration, every Congress, every Senate, up to this point has failed to give us cheaper prescription drugs in the United States, as we have continued to pay more and more. We pay 70% more in 2025 for prescription drugs than we did in the year 2000. That is an abject failure on the part of our government. So from the executive branch, we have a different approach, an executive order that seeks to bring down the costs of prescription drugs in America and spread out the cost among other developed countries in the world. This is a government approach with the pharmaceutical industry to bring up the prices around the world so that they can come down in the United States. So we're going to break this all down for the community, because as you know, if you've lived with a long-term chronic disease like obesity, or have loved someone like my wife who lives with rheumatoid arthritis, this is potentially massive news, as some people have medications that have them cost them so much that they're looking at ultimately skipping a mortgage payment some months, being late on a car payment. This just should not be in the United States. So this executive order essentially calls it out for what it is. It's a rigged system in which the United States pays 2 to 3, up to 4 times, in some cases, even on some of the drugs that are arbitrated by Medicare via the Inflation Reduction Act, up to 4 times the amount that they're paying around the world in other developed countries. So the goal is simple with this executive order, and that's that the U.S. shouldn't be charged more than any other developed nation for the same drug. At its heart, it's the idea that the world needs an equalization when it comes to who's footing the bill. When 2/3 of the pharmaceutical profits are coming from the United States, but we only represent 4% of the world population, this is out of balance. Now, you can argue whether that's an exact number. What you cannot argue is that we pay more in our system than they do around the world. That is an indisputable fact. And to argue against it, if you're American, is dumbfounding to me. So how will the government enforce such a policy? That is sort of, as we listen to the White House press briefing, that is sort of what we were left going. You just informed us about what the problem was, and you said nothing of how it was going to be fixed. And so once we got our hands on the actual executive order, we were able to sort of break this down for you yesterday on our Substack. So first, the most favored nation's pricing will be the new standard for insurance companies. So Health and Human Services over the next 30 days will notify pharmaceutical companies that they're expected to match the lowest price they offer in any similarly developed country. So second, the direct-to-consumer access piece is a huge part of this. So it's going to start with leveraging the Inflation Reduction Act and some of the infrastructure that is built around the government being able to arbitrate the cost of medications downward. This didn't exist last time the Trump administration tried this. So Most Favored Nations was tried back at the end of the Trump administration, but there was no legal framework for the government to arbitrate the cost of medications, which was its first challenge. They also skipped a public comment period that was required. And so this led to it being immediately challenged by the pharmaceutical industry in court, which should be the first tell for you who doesn't want this to happen. If you have any doubt that this is good for people, if the pharmaceutical industry is suing to try to stop this kind of thing, you know that it's not something that they want, right? So I think that the interesting thing about this time around is that there's actually legal framework, which is why an executive order can work. An executive order cannot create law. An executive order can't force a pharmaceutical company to bring the cost of their medication down. But if an executive order can tap into the government's ability to carry out the law in specific ways that the executive branch sees fit. And because the IRA exists, that is why this has a much better shot of being effective this time around versus last time around. So Health and Human Services is instructed to create a pathway now that allows drug companies to sell medications directly to patients at those same lower arbitrated most favored nation prices without insurance or pharmacy middlemen getting in the way. So this is sort of the government's approach to helping prop up programs like we've seen pop up with Eli Lilly and Novo Nordisk. Lilly Direct, NovoCare are direct to patient programs that are offering these medications at cash pay prices. What the Trump administration simply is saying is that we're going to direct the government agencies to make this easier for pharmaceutical companies to move around the PBMs, right? Now, this comes with concerns for sure, right? I don't want to just switch where the profits go in this country. I would like to see the money that is saved passed on to patients, right? We don't just want the PBMs to lose their cut while the pharmaceutical companies just grow bigger and bigger and bigger. And I also have concerns about these programs as they exist now and to the level that they cut out the local pharmacy. Your mom and pop pharmacy is a massive piece of the puzzle in the American healthcare system. They're not just a place that you go pick up drugs. They're the ones that are looking at all the drugs you're on, looking to see if, oh, this prescriber prescribed this, but this prescriber prescribed that, and they may not have known that you were on this and these two drugs interact. Or, they just know you. They know who you are. They know what you're dealing with, and they can help you navigate the experience of starting a new medication or exploring ideas of other medications that you could talk to your prescriber about. We do not want to lose local independent pharmacies. And so anything that happens needs to have some safeguards in place to make sure that we ensure the safety of our local pharmacy. The third focus is on the importation of medication. So this is where I see the door opening for the potential of 503B compounding pharmacies to maybe act as a leverage against the pharmaceutical companies if they do not wish to comply with bringing the cost down. So if drug makers do not comply, the administration has opened the door to imports of safer, lower cost drugs from other countries. And if you follow the compound GLP-1 saga, you know well that APIs, the active pharmaceutical ingredients, from these medications can be brought in from other countries and made available to compounders in the U.S. and are able to be brought to market well below brand name list prices. We've seen this with GLP-1 compounded drugs. Could this be the administration's nod to the role of 503B compounding pharmacies in reducing prescription drug costs? I think that it could very well be. Now, it hasn't been spelled out that way, but I think that this would be a really good little open door within this executive order to leverage a plan like we've seen from Mr. Jeff Cook, CEO of Noom. We brought you that interview just a few weeks ago. So potentially leveraging compound and generics from overseas to help drive prices down in the U.S. if there is not compliance on the pharmaceutical side. Antitrust enforcement would be the fourth sort of lever that this executive order is addressing, and that would be utilizing the Justice Department and the Federal Trade Commission to investigate any price fixing or market manipulation that may be keeping drug prices artificially high. Now, you have to wonder, even with the direct-to-consumer pricing that we've seen from Eli Lilly and Novo, kind of interesting to see they're priced exactly the same, about $499 a month, even though, and we'll get into this a little bit later in the podcast today, we've seen that that Wegovy is far inferior to Zepbound. We saw that in the Surmount 5 data. You're going to get about 13.7% weight loss with Wegovy over 72 weeks compared to Zepbound, where you're going to get about 20.2% body weight loss over that same period of time. They are not the same. One's a GLP-1, one's a GIP GLP-1. But I digress. We'll get into that a little bit later. It's just interesting to me to see the prices are the same. The fifth possibility that they can use as a lever against the pharmaceutical companies to sort of comply here is they may review whether export of raw materials or drugs is driving up domestic costs and take action to address it. And then sixth, utilizing the FDA, who has been directed to review whether certain drugs that are overpriced, Ozempic, or poorly marketed should have their approvals reexamined. So basically taking levers within the existing law, within existing policy, within existing administration agencies to act as levers to get the pharmaceutical companies to comply. Whether this works, TBD. So of course there's going to be a fight. Of course, it's an executive order. Of course, it's going to be challenged in court. But don't we want to see it succeed? Don't we want to see lower drug prices in the United States? Don't we want cancer patients to not get a diagnosis and then just be screwed? Don't we want to see our senior citizens pay less for medication and retire comfortably knowing that they're going to be taken care of, that their health is going to be looked out for? Don't we want that? And hasn't every other plan that we've seen in the past failed us dramatically? Even the Inflation Reduction Act, we learned yesterday, still gives us drugs that we arbitrate the cost for at 5 times the cost of other developed, or 4 times the cost of other developed countries. Even the best case example that they were able to give yesterday is still 50% more than they're paying in other developed countries. This is a problem. We should want this to succeed. So why might it work this time? We talked about this a little bit earlier. Trump tried something like this at the end of his first administration because it skipped some procedural steps and did not have the IRA framework. It was immediately taken to court. There was a temporary preliminary injunction granted in that lawsuit right away, and the Biden administration came in immediately and stopped fighting it. So it went away. And now it's different because the IRA was passed in 2022, giving that framework for Medicare to have the authority to negotiate drug prices. And this actually gives the administration a stronger legal foundation. So if they go through the right process and use these levers appropriately, this could be legally enforceable and much harder for the pharmaceutical companies to stop. So will this help people with private insurance? Because this, again, is using the Inflation Reduction Act. Well, it starts with Medicare, but if it works, it sets a powerful benchmark that could ripple through the rest of the system. So once the government secures these lower prices, employers and insurance will demand the same. Pharmaceutical companies are already under fire. They're already taking a ton of heat in the United States for charging Americans several times what they charge in other developed nations. So here's what changes the game. During the press conference, we learned that this isn't just a domestic fight. It's a global strategy that is a combined effort between the pharmaceutical companies and the United States to try to make sure that the cost of these medications is equally and fairly spread out among the world. And this is a huge shift because for years, the U.S. government and the pharmaceutical industry have sort of been at odds over drug pricing. Now they have to work together for their mutual benefit. And I think that this may be the way that this could work. So that's the most favored nations in a nutshell. You know, I really think that the biggest, most compelling piece of this in the near term, as it relates to the cost of GLP-1 medications for your average person on the street, is that opening the door to these direct to consumer programs. If Lilly Direct, for example, would just come out tomorrow and say, we're going most favored nation prices, then you're likely going to see Zepbound at a couple $100s a month. That would be massive. That would be massive. But it also brings up all sorts of other questions, like, would it just put the medication back in shortage? Does that open compounding? I said at the outset of this year, and I took a ton of heat for it, and I take a ton of heat just for talking about this, because I can't mention anything that this administration does because it's such a lightning rod. But I care about patients. I care about accessibility to GLP-1s, and I care about sick people getting treatment. And the president is who the president is. This administration is who the administration is. Ain't none of us changing that, right? So right now, what do we have? I was bullish on this because we've got a bull in a china shop here. We got a bull in a china shop situation, and we've got disruption. And I think that's what this system sorely needs. And I am bullish that by the end of all of this, when the dust settles, more people will have better access to medication than they did before. And that is what I hope for. We have to be hopeful. So what happens over the next 30 days or so? The HHS has to send new pricing expectations to pharmaceutical companies. If a drug maker fails to adjust prices, new rulemaking processes can begin within these federal agencies. And those processes include a public comment and legal review period, but it ends with the government having the power to help to bring these prices down. And important pathways and legal enforcement and approval reviews are also on standby if there is resistance from these pharmaceutical companies. So all of this will be stuff that we will be watching extremely closely. Make sure you jump over to Substack and follow along and get updates as they happen in your inbox. On the topic of accessibility, we won't belabor this because we've talked about this for a couple of weeks, but CVS dropped Zepbound in favor of Wegovy. And what was really interesting that happened this week, and we're going to talk about this in our little interview that I'll play here in a moment with Joe Zucchi, who has the change.org petition against CVS Caremark, but the Zepbound 5 data dropped. So if CVS is going to just force you over to Wegovy, there are some key points from the Zepbound 5 data that you're going to want to make sure that you take to your doctor when you fill out a formulary exclusion and you fight that battle with your insurance company. Listen to these staggering numbers after 72 weeks in the Zepbound trial. So part of the cohort was on Wegovy and part of the cohort was on Zepbound. After 72 weeks, patients on Zepbound delivered an average weight loss of 20.2% versus 13.7% with Wegovy. That's a 47% greater alternative or greater relative reduction in body weight with Zepbound over Wegovy. And crazier than that, one of the things that they're monitoring now versus just the straight BMI is this waist circumference. People on Zepbound lost over 7 inches around the midsection compared to only 5 on Wegovy. That's a huge difference. So we're talking about two drugs that are definitely not comparable. You talk about not even having comparable doses. When you look at the Zepbound data, once you get to 5 milligrams of Zepbound, you get above 5 milligrams, there's nothing comparable. Wegovy doesn't even come close. It's still a great medication. It still has some great benefits, cardiovascular benefits. We've seen those clinical trials. We've seen other trials start up in the way of addiction and Alzheimer's. It's an amazing drug and a breakthrough in its own right. But Zepbound definitely is the king of the hill when it comes to chronic weight management. And as a reminder, and we'll get into this a little bit later, is the only approved treatment for obstructive sleep apnea. I should say it's the only medication approved for mild to moderate obstructive sleep apnea in people with obesity. But if you want to fight back against these shenanigans with CVS Caremark, it is super important that you're made aware of the reality on the ground. What can we do beforehand, and what do we do when that July 1st date hits? The first thing we can do is we can get on board with the change.org petition, and Dr. Joe Zucchi dropped into On the Pen to talk a little bit about that this on the topic of accessibility and sort of what's happening in the landscape of being able to access Zepbound and other GLP-1 medications. We've had this whole backstory of what's going on with CVS Caremark and preferring Wegovy as the optimal treatment for obesity. Obviously, this is affecting hundreds of thousands of people, and we've got a lot of resources for you coming today on our Substack. But one of the things that we wanted to highlight on this week's podcast for you is a petition that's going on at change.org. That petition started by a physician's assistant out on the East Coast. His name's Dr. Joe Zucchi. And Joe is here. He's a physician's assistant. He's here to talk about the petition that's been started and what his hopes are for that. Joe, welcome to On the Pen.
Hi, Dave. Thanks for having me. Appreciate it. And looking forward to talking and discussing together.
Yeah. Thank you for making the time, because I think this is a really, really important thing to get out there. First of all, what were your thoughts initially when you saw that CVS Caremark was dropping Zepbound?
Yeah, it was disheartening. I think, sir, for so many patients, Zepbound's been an incredible medication, and Wegovy is excellent as well. But for a lot of patients, Zepbound has been superior, and to have the rug pulled out from underneath them and just to lose coverage in the middle of the year like this for no great reason is just frustrating. So I just kind of felt the call to advocacy to kind of highlight the reasons why I was concerned by this. And on behalf of my patients and people across the country, it seems like it's gotten a lot of traction. So hopefully we can instigate change.
Yeah. Absolutely. And in advocacy, I mean, anyone who's sharing and communicating across the social media platforms about GLP-1s, I think it's important to find your little way that you can advocate for, especially accessibility, because as we, over here at On the Pen, we're obesity medicine news from the patient perspective, but nothing that we talk about doesn't touch the topic of accessibility. And it's the largest thing facing patients. You can have the greatest treatments in the world with the greatest peer-reviewed data in the world, but if people can't access that treatment, then it doesn't mean a whole lot to people. And so I appreciate the fact that you, as a physician's assistant who is caring for patients with obesity, are taking that extra step to elevate the conversation here. So tell me a little bit about the petition. What is your ask of CVS Caremark here?
Yeah, so I think first I just wanted to kind of, highlight to Caremark and hopefully those involved in this decision why there are some concerns behind this choice. And I understand behind the scenes it's price negotiations and so forth. And Novo claims it's not an exclusivity deal they signed. It's more of just Caremark negotiating price and rebates and such. But these medications are not on the same par here. So first we know, and this just kind of was published yesterday, but the SURMOUNT-5 trial was literally a head-to-head study comparing Zepbound, tirzepatide versus Wegovy, semaglutide. And this was a 72-week-long trial. And basically, patients on Zepbound lost 20.2% of their body weight, and patients on Wegovy lost 13.7%. So we're talking a 47% more weight loss on Zepbound. And we see that in practice. A lot of patients have tried both medications and perhaps switched, and most found Zepbound superior. Again, Wegovy is a fantastic medication. It has cardiovascular data, and it's also, it works very well for a lot of people. But when you put them head to head, a lot of patients will prefer and find superior results from Zepbound. And I'm sure many of your followers agree to that as well.
Yeah. This is probably a crude analogy, but having taken both Ozempic and Mounjaro at different points in my journey, the way that I was describing it to somebody else the other day, I was like, it's like Zepbound is kind of a smooth experience, and Ozempic is like ripping the filter off of a cigarette. It's harsh. It just tends to be really harsh for people in terms of just its blunt mechanism at sort of, slowing that digestion and really making you feel in your gut, full in your gut, where Zepbound seems to act a little bit stealthier in the brain. I realize there's no clinical data that really backs that up, but anecdotally, it seems to be people's experience.
Yeah, I agree. I think, that's kind of my second point is not only superior efficacy, but number two is better tolerability. And that's important because at the end of the day, maintaining care and staying on these medications long-term is often necessary. And if somebody is discontinuing the medication after a few months due to nausea or vomiting or GI issues, then that's no benefit to them as to stay on that medication. So when we see, the outcomes in the trials, people do tend to have a bit more GI side effects in the Wegovy group compared to the Zepbound group in that SURMOUNT-5. But we see that just in clinical practice. And I talk with colleagues all the time who are in, Obesity Medicine Association, and many patients have more queasiness, more nausea with Wegovy, and with Zepbound, that's less common. It may be due to the GIP agonism that may have an antiemetic effect and cause less nausea. It may be just, certainly it's a different molecule. But tolerability is important, and we need patients to maintain, therapy, and hopefully the best action is to find the medication that fits somebody the best. And so my second point was primarily around that. I think my third point starts to go into, Zepbound is unique in that it's not just a GLP-1. It's easy to lump it into the same category, but this mechanism is different because tirzepatide targets two hormones. It targets GLP-1 and GIP, so it's a dual agonist. And that's unique, and that may have more metabolic benefits. We certainly see the A1C improvements on Mounjaro seems to be a bit superior than Ozempic. And so for Caremark to just consider these one and the same is not necessarily fair either. And on top of that, Zepbound is the only medication that's ever been approved for sleep apnea. It is actually an approval for obstructive sleep apnea, moderate to severe sleep apnea, and patients with obesity. And so for a lot of patients, they may have coverage because of that, or they may be using it because of that indication. And so Wegovy does not have that data, and there is no medication that has that besides Zepbound. And the only other options for sleep apnea are CPAP or BiPAP devices, or the Inspire, surgical device. So again, more rationale as to why Caremark should be considering all these facets here. I think as we kind of go down the list, the next thing I wanted to point out was dose flexibility. Zepbound has 6 dosages. And often insurances allow us to pick whatever dose we want to and titrate up or titrate down. We have a lot of flexibility there. Some insurances require us to stay on the maintenance dosages of 5, 10, or 15 for chronic use. But regardless, there's more flexibility there to help figure out what dose works well for each patient. And everybody's different. We shouldn't be forced to titrate up. Unfortunately, with Wegovy, most insurances require titration to the top 2 dosages. Those are the only approved maintenance dosages. And so that's also a problem for patients that may be at their goal weight and want to be on a lower dose, or perhaps, just needed to stay at a lower dose for other reasons. So as you may understand, that's probably an important point for a lot of people.
Yeah.
And so those are kind of the big things. And then I think the next point was just more as in general, forcing medication change for no good reason is never a good outcome. If we're doing this purely for the, Caremark executives to decide what works best for their bottom lines, that's just frustrating because changing medications when somebody's doing well, that's just unfair. Somebody is worried about changing medications. This has caused anxiety. I'm getting emails from patients. We're seeing how many people are affected by this on the petition, leaving comments about their journey. And, to have patients switch medications, this is not like changing from Advil to Aleve. This is much more involved here. If somebody is at a higher dose, where do we switch them to? There's no data to tell us that. We're going by our intuition and our experience, but there's no direct correlation. In fact, if you look at the weight loss, after 5 milligrams of Zepbound, 7.5, 10, 12.5, and 15 have no kind of equal dose on the Wegovy side, right? We just talked about that. Wegovy's 2.4 milligram dose, averages around 15% weight loss, and we saw 16% weight loss at the 5 in Zepbound's trial. So there's technically isn't even an equivalent there, but that's an issue. And I think, patients need to be very mindful. If they're off Zepbound for a few months while they're going through this process of switching medications, they need to be very careful if they switch to Wegovy, not to start at the highest dose because they're going to have nausea. We need to titrate them up unless we're doing a conversion quickly. And so there's a lot of complexities, and I'm sure Caremark is getting, there's going to be appeals and prior authorizations, and there's going to be arguments, and people are going to be sending them letters. And all of this is just kind of unnecessary in that sense.
Yeah, I think you just touched on something that hadn't crossed my mind in terms of this conversation about CVS, but I've definitely seen that where patients or followers, I should call them,
Sure.
followers of On the Pen who have switched from a high dose of Zepbound, and their doctor says, well, you're at the 15 milligram dose of Zepbound, so we're just going to go ahead and switch you over to the 2.4 milligrams of Wegovy. Yeah. And that has been a rough journey for them. I mean, some of them ended up in the hospital because I think what people don't understand, and even some of these treating physicians don't understand, is that Zepbound, and you touched on this earlier, is 5 times more a GIP medicine than it is a GLP-1. So Wegovy being a straight GLP-1 medication is not going to be an equivalent. And so I think that's, but then, you run the risk of having people start at a low dose of Wegovy and then backsliding in their progress when it comes to their weight management. So there are a whole host of things, and I appreciate from the provider perspective, you highlighting those issues.
Yeah, I think that's really important. This is just it's going to lead to a lot of distress for patients and providers because we have to meet with patients, discuss this, help them understand it's a different pen. Certainly, it's still an easy pen to use, but there's a lot of transition here. And to have hundreds of thousands of patients, have basically a month or two to figure this out is tricky, especially when we know for a lot of patients, their experience, maybe they had tried Wegovy in the past and they switched to Zepbound afterwards. So I'm hopeful that we can certainly, showcase to Caremark that this is not an easy swap and why both medications should be available because they're both great medications. And at the end of the day, PBMs or pharmacy benefit managers should not be controlling care. Right. This is up to a provider and a patient to figure out what's the best fit for you. We're going over your medical history, your family history, your personal history, what you've tried in the past, cardiovascular history, perhaps sleep apnea. All these factors go into it. And, each person has a different amount of weight they're looking to lose and how much, everyone has a different lifestyle and background. So at the end of the day, we should have more tools available and not less. So when Caremark is choosing to withhold access to arguably the most effective medication in the market, that just leads to a bad taste in my mouth and for many patients, just frustration. And so at the end of the day, I hope this petition sheds light on the issue. It's been great to see the press it's gotten from Bloomberg to New York Times. And the change petition, we've already gotten over 4,000 signatures. And it's continuing to grow. And I'm hopeful that we can showcase the power of the community and how many people are really passionate about this. And we can, I'm going to plan on sending this and hopefully pass this along to the Caremark executives, the CMO, the president, the vice president, and say, hey, look at what your change has impacted. Are you realizing all of this before you make this change? And maybe they can rethink their decision.
Yeah, I love it. Joe, I'm going to link your change.org petition in the show notes of the podcast today. Change.org is where this petition lives. Folks can also find you specifically on X at JPZ Fitness and at LinkedIn at Joseph Zucchi, Zucchi. We'll link those as well in the show notes if you'd like to follow along with Joe. I hope that we can have you back and have a longer discussion about some of the other topics. But I love what you highlighted here. The big problem here, and I think we see this the same, is The second PBMs start to practice medicine, we have very, very, very big issues. And this is exactly what that is. And you've highlighted some of the most important issues that I think need to be raised on the physician side. So I really appreciate you taking some time out today.
Oh, I appreciate you. And, thank you for showcasing things like this to the public. And a lot of people appreciate, your just great news reporting on this side of the GLP-1 world for both diabetics and for patients with obesity. And, at the end of the day, I know this causes a lot of fear and people are concerned and we want to raise advocacy here. But I do want to just, send the message out to people that, we're all in this together. We, at the end of the day, regardless of what the outcomes are, if you have to change medications, know that, this is not the end. Yeah. As a provider myself and on behalf of my colleagues that work with obesity medicine and with patients struggling with obesity, we understand your journey. We understand your struggle. We understand everything you're going through, and we don't want you to feel alone. Communities like this hopefully help to make you feel like you're part of something bigger than yourself. And whether you're struggling with your weight or seeing success, hopefully, over time, these types of things will continue to lead to better treatment options. And the future is very bright with medications. I just got back from the Obesity Medicine Association conference, and there's so many great things in the pipeline. Over time, I think costs will come down, access to care hopefully will improve. And at the end of the day, we want patients to have better health and quality of life, and that's definitely in reach. So as frustrating as this stuff is, stay strong. The outcomes are going to be worth it, and all your progress is going to continue to pay off.
Yeah, awesome. Joe, thank you for being here. Really appreciate you joining us here on the Pen today, and we'll do it again.
Thanks so much, Dave. Really appreciate it.
Joe Zucchi. You can find his change.org petition in the show notes of this podcast. Please go over there, sign the petition, let your voice be heard. Want to leave you this week with just a few things you can do. If you are someone who is facing the changes that are coming to CVS Caremark patients, if you're on Zepbound and wish to maintain access, some of the things you can do before July 1st, ask your doctor for a letter of medical necessity. Get that going now. Your doctor should know what that is, but we'll put that in the Substack today and help you navigate that as well. Make sure you've got your prior authorizations done and you have done what you can to do your 3-month prescription fills. If it's time to bump up, perhaps see if your doctor is willing to write that 3-month prescription to keep you on as long as possible. Most insurance plans will let you fill 3 months at a time, and the savings cards will let you use the savings cards. So take advantage of that if that's possible. Download, and we'll have this linked on our Substack today as well, the SURMOUNT-5 data that we talked about today that compares Wegovy and Zepbound directly in a head-to-head trial over 72 weeks. Sign and spread Joe's petition. Sign it, share it, save it, do all the things, and then reach out to your HR and benefits manager right now. Start talking about this with them and see when these changes take effect and see if they can sort of raise the flag with their insurance providers too and just sort of get some voices getting loud about this from all directions. Now, once July 1st hits and these changes do take place, you want to make sure that your doctor appeals any denials of your prior authorization immediately, citing that SURMOUNT-5 data, especially if you're on anything over 5 milligrams of Zepbound. There is not a comp on the Wegovy side. SURMOUNT-5 shows that explicitly. If you have moderate to severe obstructive sleep apnea, perhaps request coverage under Zepbound's FDA approval for that. That is a way. There's no other drug. Wegovy is not approved for obstructive sleep apnea, but Zepbound is. If you need a sleep study done, those can get tricky to get covered by insurance too, but they can be done online now for just a couple $100. They'll send you the equipment you need to set up in your home, and you can get a diagnosis of obstructive sleep apnea right from your home for a couple $100. That may be worth it for some of you. We will bring you more information on that in the Substack as well. Ask your provider if a compound medication might be an option, or the direct to manufacturer, the Lilly Direct option may be an option as well. These are some things that you can look at in the interim. Of course, compounded stuff is not all created equal, and things have gotten a bit squirrely since 503Bs have lost their ability to make this. Now they're 503A, they're custom formulations, custom doses, etc. Not all of them are created equal, so do your due diligence to find out where the medication is coming from. And of course, document everything. Keep receipts, appeals, cost, denials. This stuff is probably going to end up in some sort of legal mess at some point. So just document everything in case you ever become a part of that. everyone, thank you for bearing with me. It's a little bit longer than the podcast usually goes, but these topics are so important to cover. I hope that you found this information helpful. If you did, again, please give it a 5-star rating and review. Jump over, grab our Substack. I am feeling better and better about our ability to be a loud and moving force for change in this movement for accessibility to obesity treatment. Thank you for being a part of it. Thank you for being the best part of what we do at On the Pen. I couldn't, wouldn't, and shouldn't do it without you. Until next week, y'all have a great week, and thanks for hanging with me today.